Hello, everyone. Welcome back to Clinician's Brief, the podcast, where we have the conversations behind the content. I'm the host, Dr. Alyssa Watson, and today I'm super excited to welcome Dr. Søren Boysen to discuss a very timely and practical topic. We'll be talking about the benefits and limitations of point-of-care ultrasound, often called POCUS, in general practice. Dr. Boysen is a professor of veterinary emergency and critical care at the University of Calgary in Alberta, Canada. He recently co-authored a series of articles for Clinician's Brief, examining how POCUS can provide rapid, targeted clinical insights when used properly, but also looking at the potential risks of misdiagnosis and delays in care when it's not. So in this episode, we're going to begin by exploring the benefits of this really increasingly accessible diagnostic tool and how general practitioners, such as myself, can integrate it into their practices to enhance patient outcomes. But then after the break, we're going to shift our focus a little bit and talk about the limitations of POCUS and the critical considerations clinicians should keep in mind in order to avoid some pitfalls. So thank you so much, Dr. Boysen, for giving us your time today. Before we jump into this conversation, would you introduce yourself to the audience and just tell us a little bit about yourself?
Absolutely. Thank you for inviting me on to the podcast. As you mentioned, I am based out of the University of Calgary. I am a small animal emergency and critical care specialist. I did my training here in Canada in Saskatoon. I then did a year in private practice on the West Coast, Prince George, before going to the East Coast, the Atlantic Veterinary College, for my internship. I then went down to the States to do my a year in practice, actually, as a referral emergency doctor, and then did my residency at Tufts in Massachusetts. And that's where we actually started the initial point of care ultrasound process, because during my residency, I had to produce a research article. And that research project was looking at the human literature. At that time, it was the FAST exam. And that's where it actually all started. We started developed the FAST exam when I was a resident, and then it's evolved from there over time and become, as everybody knows now, point of care ultrasound. So we've moved from looking for simple fluid to answering all the questions that we do at the patient side. So in the last 20 years, it's been great to see how point of care ultrasound has really been embraced by general practice and emergency practice across the board, as well as specialists. So it's really nice to see it integrated into daily practice. And recently, I was recognized with the Jack Maris Scientific Award for advancements in point of care ultrasound in the veterinary medicine.
That is wonderful. And it actually leads very well into my very first question, which is, what are the important differences between what we would consider a formal ultrasound and these point of care ultrasounds that we'll be talking about today?
That's a fantastic question, and there is a huge difference between the two. So for formal ultrasound, that's years of training. You have to really be an expert, having lots of either years of ultrasound experience under your belt or doing a residency is probably the most classic way to be considered a formal ultrasonographer, whether it's in radiology or cardiology. And the big difference there is years of training to become a specialist in ultrasound or imaging specifically, which requires, when you ask for an abdominal ultrasound, for example, which is formal, they're going to look at all the possible options that you would look for in the abdomen. They'll scan all organs with an open list of differential diagnoses away from the emergency in a specific room, which will often take a minimum of half an hour, often up to an hour, to get the answers that they're looking for, because there's no stone unturned. They're looking at all the organs with all possible differentials. When it comes to point of care, one of the biggest differences, we do these exams in under 5 minutes. We don't look at all the organs. We look at specific organs to answer key, usually binary-driven questions. So does our patient have free fluid, yes or no? Simple question that everybody can answer when it comes to the abdomen, as opposed to, I wonder if it has wall layering changes or it has a problem with the pancreas. We don't look at those things. We look at things that we've also shown evidence that general practitioners without advanced specialized training can find an answer to. So it's specific, targeted, goal-orientated with a focused question. And it doesn't look at all organs. It doesn't require specialists. And the nice thing is, it's done by the person that has the probe in their hand, usually with a question they want to answer before they put the probe on. So it's a very closed-ended type of approach, as opposed to an open-ended approach that our formal ultrasound will do.
So one of the things that you just mentioned is that these exams are quick. Are there any other key factors that make POCUS particularly beneficial in stress reduction, when we're dealing with our patients that are oftentimes anxious or even unstable?
Yes, another excellent question, and absolutely. And there's several key factors that it comes down to. When we do point of care ultrasound, the big thing is we bring it to the patient, as opposed to, again, formal, where you take the patient away and you usually go to an ultrasound studio or suite or an imaging area. We do not need to compromise stabilization efforts. Our patients can continue to receive oxygen. We can continue to place IV catheters, give IV fluids. Whatever emergency stabilization needs to be done can occur concurrent, and we don't interrupt that when we do our point of care ultrasound evaluation. The other big thing is, unlike a formal ultrasound or removing a patient to get radiographs, we often have to restrain them in a certain position. We have to put them in lateral recumbency. We have to put them in dorsal recumbency for a lot of ultrasound exams. The nice thing about point of care, which decreases the stress on the patient, and very key component to this, we scan them in the position they're most comfortable. So our patients in respiratory distress, they breathe more comfortable when they're standing, for example. So we don't force them into a position. We don't restrain them rigorously to do any particular procedure. We leave them in the standing position with the minimal restraint possible so that we can complete the exam. If they come in lateral, we scan them in lateral. So we scan them in the position they are most comfortable, that is least stressful, with the least amount of restraint, which again, for low stress handling in cats is a big thing that we're seeing, as well as in dogs, but very relevant in cats. So we are able to do that with minimal stress, minimal restraint. And I think that's a key factor as well. And if they need anxiolytics or they need analgesics, then we often administer those, give them a few minutes to kick in, and then continue our point of care exam. But it's minimal stress because of the fact it's so non-invasive and there's so little restraint required to do it.
That's wonderful. Also, one of the things that really interests me, especially because I do some part-time in-home care, are some of these advancements that we've seen in handheld ultrasound probes, these options that will attach to a cell phone or attach to a tablet. Do you think that these devices are going to affect practitioners in the future, especially when we have a little bit more, mobile practitioners or relief veterinarians that need to go from practice to practice?
Absolutely, 100%. With the rapid speed at which we see the progress and the changes in ultrasound, how it's actually improved from big console units to, exactly like you said, handheld units, I'll make a prediction that might not be quite 10 years. When I say 10 years, just for the sake of making a prediction, every student, in addition to having a stethoscope when they go through vet school, is going to have some type of device that'll allow them to assess with ultrasound. So I make a prediction that alongside the stethoscope, they're also going to have some point of care ultrasound device. The handhelds, whether they plug into an iPad or an iPhone, or whether it's Bluetooth connected, I'm willing to predict that we will see a lot more of that in our student training programs. But I'm also willing to bet that that's this nice thing, is it puts it in the hands of general practitioners for minimal cost. And we did do a study comparing several handheld devices to show that you can answer all of the point of care questions that we ask and answer at this point in time with a handheld device. So that makes it more cost effective. And we're not looking for extreme detail that might require a higher resolution, more expensive unit to do. We're often just looking for those big key questions, fluid, yes or no. You don't need an expensive machine to do that. You can do that with the handheld units. So that's actually a really nice application that a lot of people don't have the confidence either. They don't feel, I don't have the training. I feel that there's machines in the corner. It's gathering dust. I just look for a cysto and that's it. No, you can do so much more than that. And I do think the handhelds, even though a lot of them don't have the resolution that would allow you to look for a pancreas or see the clear wall layering, we did the research to show that the point of care questions we ask and answer can be answered with the handheld units. So I think it's going to be hugely impactful.
Let's talk about those point of care questions. You said already, the one you've thrown out a couple times now is there fluid? And that's one that even I feel confident at. I can tell if there's fluid there. But these are really binary yes or no answers. So besides that, what are some other examples of binary questions that you think general practitioners should be able to answer?
The next biggest one that I think a lot of people overlook, because the lung seems to be one of those things that's been taboo historically, that no, you can't see through air, ultrasound will not help you. I honestly think after looking for free fluid in the abdomen, looking for the artifacts at the lung surface with ultrasound is the second easiest thing to do. There are some things you need to be aware of, so that a little bit of training is required, but looking for vertical white lines, which we call B lines, indicating decreased air in the lung, to me is the next easiest thing you can do after looking for free fluid in the abdomen. So looking at the lungs for B lines, obviously looking for fluid in all the cavitary spaces, whether it's in the abdomen, the pleural space, the pericardial space. Those are simple questions I believe anybody can answer. Along the lines of decreased air in the lung, I put a probe on a dog or a cat that's in respiratory distress, and I see a lot of B lines. My next question, especially if it's got a murmur or I'm thinking it could be heart failure related, is the left atrium enlarged, yes or no? I do believe that is a skill that a lot of people don't believe they can do, but I do believe with correct training, we've shown the research that non-specialists can acquire the correct window for the left atrial aortic ratios in a very short period of time to be able to answer the question, should I give furosemide, yes or no? So I do think that's a question that we should be able to answer. We can obviously look for and find the urinary bladder. A lot of people are already familiar with that, but we can calculate the volume of a spear and get an idea of what the urine volume is. And if we do that twice over 2 time periods and see what the difference in the volume is, we can actually figure out urine production very easily with point-of-care ultrasound. Again, a very nice thing. You got a cat, Jess lilies, you're worried about anuria. We can measure that without putting a urinary catheter in potentially and say, yes, it is or is not producing roughly the urine that it should be producing over time. So that's another really easy one to do. One that's received a lot of attention, gallbladder. Many of us are comfortable finding the liver in the gallbladder. Then the next question is, do we have thickening or striation to suggest edema, which says we've got a halo sign? And I believe that is one that is very easy for people to pick up as well. So I think we can get the gallbladder halo sign easily identified. In our female intact dogs or cats, pyometra is another one that's, if it's closed, can sometimes be challenging to diagnose. It adds that layer of confidence to say, yes, I know exactly what I'm dealing with. This does have a fluid-filled uterus that is present between the colon and the bladder. Then if I trace it cranially into the more cranial parts of the abdomen, I can see it split into the horns. You're now feeling 100% confident that that is your true diagnosis. I find that one easier to diagnose with ultrasound than radiographs, for example. So those are probably some of the big questions we ask and answer. There are a lot more that can be done. So with more experience, and it does take a bit more practice, we can look for renal pelvic dilation. So our cat's coming in and we're thinking, it's not eating, it's not drinking. We run a little bit of blood work in-house. It's azotemic. Is this going to be something that we can diagnose? Yes, we can look at the renal pelvis and say, in a cat, if it's more than 13 millimeters, you pretty much can hang your hat on that being a ureteral obstruction with that degree of dilation of the renal pelvis based on the research that's out there. So that's one I think we should be looking at, but maybe a little bit later after we get more confident with our skills. We just did a research project here with our students to show that free air in the abdomen, although it was always considered, again, one of those things, no, you can't do it, but we've managed to break that down into simple, small steps and binary questions to say, yes, our students with about an 85% accuracy can identify free air in the abdomen when they're attested with ultrasound clips. So
that's amazing.
That's one that can be done. And then volume status. That is definitely more advanced, more emergency side. But if you're struggling, do I give them fluids? Do I not give them fluids? We can look at ultrasound to help us make that question. Is the vena cava distended? Do we have changes in the left ventricular lumen that might influence the decision? But I will say those take a bit more practice for sure. So there is a continuum. And I think it's the neat thing about point-of-care ultrasound. If you look at the evolution of it, what did we look at originally? Trauma dogs, that was it for free fluid. That was our whole point of care. One question, one answer, is there free fluid in the abdomen? Then we built from there and said, well, can we look at free fluid in the pleural and pericardial space? We added that. People got comfortable with it. Then we said gallbladder wall edema. People got comfortable with it. We add one essentially binary assessed question at a time, master it, move on to the next. And it's the same thing when you learn. You don't need to say, oh man, I need to learn point-of-care ultrasound. I should answer all 15 questions or 24 questions. No, start simple. Just looking for fluid is still a relevant, very clinically relevant test that you can do that gives you a lot of information and gives you a direction to go. And then if you get comfortable with it, doing ultrasound-guided interventions, for example, simple cystostasis, but taking fluid out of the pleural space when they're in respiratory distress. Easily to diagnose with ultrasound, easy to intervene, and you don't need to know all point-of-care ultrasound to be able to do that life-saving skill. So that's the thing I love about it. It builds sequentially on binary questions as you master them one at a time.
And then in the article, you talk about these, 6 very specific clinical applications, and you just touched on a whole bunch of them. You call them the 6 T's, and hopefully I don't trip over them with my T's, but it would be targeted examination, trauma assessment, triage, tracking, treatment, as you just said, and then total assessment. And so, I encourage everybody at home, check out the article and go through those 6 T's. And just like you said, we can just kind of build on them, learn one skill at a time. You do talk about studies that also show increased diagnostic confidence, when you integrate these techniques, these POCUS, into routine examinations. And so I just wondered how you think this increased confidence can improve communication with pet owners and hopefully lead to better compliance with diagnostic or treatment recommendations.
Yeah, I think that's a really good question as well. And it is true that I think one of the biggest difference between specialists and general practitioners is their level of confidence when they go in and talk to a client. A lot of the specialists will have done more diagnostics, so they'll have more pieces of the puzzle because they're going to spend more because the patient's been referred to them. So that when they go talk to an owner, they have more confidence in where they're taking that owner. And I think that's something nice with point of care ultrasound. So, for example, if we have a patient that comes in that's in respiratory stress, that's a very stressful situation for both the patient and for a lot of clinicians because they're worried, oh, it's in respiratory stress. I don't know exactly what's going on. I have to get a radiograph. I may decompensate that patient in the process of doing that. Can I provide that owner with more information on what I think the underlying cause is to give them a better feel for where we're going to go, what the cost is, what the prognosis is? When we have that information, I think we're a lot more confident in talking to clients because we are confident in our own diagnosis. And I think that's where ultrasound comes in and plays a huge role. If I use the respiratory distress patient, for example, it's a small dog that comes in, we put an ultrasound probe on, we see those vertical lines, we see those B lines telling us there's decreased air in the lung. I then check the left atrium and it's 2-to-1 relative to the aorta. I know exactly where I want to go talk to that owner. I know exactly. I'm not thinking, I should take x-rays. I'm not sure why your patient's unstable. I'm telling them it's because they have congestive heart failure. And I've narrowed the number of differentials. I'm really confident in the prognosis, the therapy, the next diagnostic steps. And it applies, same thing. A dog comes in that's hit by car. It's in respiratory distress. I'm wondering, what is the cause for that? Can I answer that with ultrasound? I put the probe on the chest. I see that I have a pneumothorax, I have a hemothorax, or I have contusions. All those things are extremely amenable to being diagnosed with point of care ultrasound. I can, again, go back to my owners, talk to them with confidence. So it's sort of like doing blood work. If your patient comes in and it's got pale mucous membranes, you got to go talk to your owner. You're like, well, he's got pale mucous membranes. It could be anemia. It could be shock. It could be vasoconstriction. We've got a few different differentials. But if I run a blood test and I see that the red cell count's low, now I can go in and say, okay, the red cell count's low. I'm confident that this is what the cause is, and I can talk to the owner about those causes. And I think that's where ultrasound is extremely valuable in building that level of confidence and decreasing that moral stress on the practitioner, because they now have the confidence to go in and answer those questions and not feel they don't know an answer and they don't know where they need to go with that patient. You've got a much, much better idea. It doesn't answer all the questions, not by a long shot, but when you find that answer, it does hugely build your confidence. And I think it gives you a lot more confidence in talking to your owners about your differentials, your next steps, the cost, et cetera, prognosis. It just makes life, I think, so much easier.
That's great. Thank you.
If you've noticed your dog having difficulty moving, jumping, or playing, it could be a sign of osteoarthritis pain, or OA pain. OA pain is a chronic condition that impacts how your dog moves and feels. Do you think your dog is showing signs of OA pain? Know that treatment options are available. Ask your vet about what they can do to help control your dog's OA pain. Tap Learn More for details.
All right, let's shift focus just a little bit, and we're going to talk about the limitations of ultrasound now. We talked a lot about binary questions and the kind of idea that ruling in pathology using point of care ultrasound is a lot easier than ruling it out. So can you explain why that's the case, offer some strategies for clinicians so that we can avoid overconfidence when we have a negative finding?
Yes, absolutely. And I think this is something that as veterinarians, we are really accustomed to on several levels on a daily basis. And I can, again, take an example of patient comes in, it's not eating or it's eating less and it's less active. One of the things we're often going to run is blood work. And if we run the blood work and we don't find the answer on the blood work, we don't then just say, oh, your patient is perfectly fine. You don't have a problem. You can't rule out something because you know something's there based on those history and clinical findings. So even the blood work didn't give us an answer. It's not looking at all the possible problems. No single test can answer all possible problems. Otherwise, it would be a magic bullet and AI would take us out of the picture and we wouldn't be needing veterinarians. So the same thing holds true with point of care ultrasound. It's probably even more relevant because when we do point of care ultrasound, we are looking at focused windows. We're not checking everything possible in the abdomen. Again, that's formal ultrasound. So because we're looking at limited windows and we're looking at limited questions that we're going to answer, if we don't assess the entire abdomen, there's areas that might contain pathology that we're not looking at because that's not point of care ultrasound. So for example, the pancreas, the adrenals, or the intestinal wall layering. So if we put an ultrasound probe on and we're looking just for fluid, we don't find fluid, we can't say there's no pathology in the abdomen because we only look for specific things. So that's the biggest reason that we can miss pathology. A negative point of care ultrasound finding does not say there's no disease there. It's just not the disease we were looking for to specifically answer. And then it comes back to the same thing, the overconfidence. Again, if we're looking at a limited area, again, if we're not doing formal ultrasound and looking at everything and we don't find a specific problem, we don't want to overinterpret that and say, well, nope, your bog does not have a mass in the abdomen. There's no neoplasia because we didn't find an obvious splenic mass. No, we can't make that decision. So I think it's similar to thinking of other diagnostics. It's a complementary test. It's the same strengths and weaknesses as a lot of the other tests we do. And it's the same thing with radiographs. If you take a radiograph and you don't find pathology, doesn't mean it's not there because you're going to miss masses or wall layering changes or pancreatitis. Same thing. So it's got similar limitations to a lot of the tests we do. When we find a positive, we're confident in that finding. But that brings us to the other problem is the overconfidence and confirmation bias. Yep. If we really want to make a disease fit, sometimes we can make it fit.
Yeah. And we're going to talk a little bit about confirmation bias a little bit later in the episode. So I just reminded of kind of the conversation I have with clients all the time when I'm talking about, fine needle aspiration or biopsy compared to, full histopathology. And I'm always saying, we're looking at a very small amount of cells. And so we might miss the area that we needed in order to get a diagnosis, and kind of like that same concept here. Another thing that can be frustrating and difficult is this lack of consensus on POCUS nomenclature, lack of consensus on protocols, diagnostic criteria, and that can lead to confusion with practitioners even in the same practice. And so are there steps that an individual practice can take to kind of standardize protocols, at least within their practice, to ensure continuity of care in their teams?
Yes, for sure. And I do think that is more so of a problem because most of the things we do are standardized in the curriculum when it comes to training our vet students. So a lot of people come out of a curriculum with a fairly standardized approach that's universal. The problem with point of care ultrasound is it was never formally taught in the DVM curriculums. So most of us have taught ourselves or have attended a specific course, and everybody's got a difference of opinion and a difference in the way that they are applying point of care ultrasound. The good thing is, I'll say that the Veterinary Emergency Critical Care Ultrasound Working Group, which is a European-based group and part of the Veterinary Emergency Critical Care Society in Europe, they are working on right now a consensus document, which is going to try and standardize whether things are novice or expert in terms of the terminology and what testing should be done. And then they're going to try and standardize some of the training protocols across the board. But that's still a few years out. So the more important question that you asked, which I think is very relevant, can we find a way to standardize it within a clinic? And I think that's going to be a communication between the members of the staff. And the best way, I think, moving forward is to come to an agreement on what the objectives are and what the clinicians within a specific facility are trying to obtain. So, for example, there are several clinics I've worked with that have decided exactly that. They want to standardize how they approach things, and they might bring us in or send their team members to a training course specific in point of care ultrasound, where they'll get the same degree of training, they'll answer the same questions, and then they can carry that back to their clinics. And then to keep it standardized within their clinics, we often recommend that they have record sheets. And again, it's going to vary depending on the comfort level of where the clinicians want to be within that clinic. But having those record sheets to say, we answered this, we didn't assess this because I'm not comfortable, I answered this and this, then it's all standardized. And the next person that comes in looks at that, repeats the exam, knows what they found, and they've all been trained the same way. But I do think then it's a matter of either getting people a similar training process. And there are, I know now, a number of point of care ultrasound individuals that will go into practices to potentially standardize that training within a group of clinicians from somebody that, quote unquote, would be considered an expert in point of care ultrasound. So those options do exist to try and standardize that. And same thing, going to some of the bigger conferences where they offer those standardized training programs. If there's a number of people from a particular clinic going there can attend that course, they can bring that information back. They can bring those record sheets back and then try to implement that across the facility to try and keep everybody on a similar page when it comes to answering those questions.
Yeah. And then I think you had mentioned that there's, there's even some data behind like how many hours you need for these short-term courses and then what it should be followed up with. So can you kind of speak to what foundational knowledge you think practitioners should prioritize when they start this POCUS training?
Yes, also a very, very good question. And I think when it comes down to the number of scans, that's probably the biggest question. And it does vary depending on the answers you're looking for. So we did show evidence that looking for free fluid, we looked at when we answered this question with our students. So we did do research with our students to say how many exams do we need before we think that that individual is considered proficient in looking for a simple question. I'll come back to the original one, which we're all using, which is still that free fluid. It was considered 20 scans. So you need to do 20 scans. So you need that foundational, what do I look for? What does free fluid look like? What sites do I need to assess in the abdomen to answer that as the foundational skills in terms of the normal anatomy at each of the sites? So we look at 5 sites. What are the standard organs we see there? Can I identify those? Yes. What does normal structures that might be confused for fluid look like? Perfect. What does fluid look like? Perfect. Got those foundational skills down. Now, how many scans do I need to do to actually be considered consistent or competent in that skill? And we've decided that that was based on the research we did, 20 when it comes for looking for free abdominal fluid. So I think the best thing for individuals wanting to break into point of care ultrasound is to really take one of those courses that gives them that foundational knowledge on the sites to assess, the organs to assess, the questions to answer between the 3 big domains of abdomen, pleural space, and lung, cardiac. And those courses are out there. They're available in often 4-hour hands-on training sessions, which is kind of your minimum. Gets your feet wet and gives you someplace to start. But once you've done that, and we emphasize this over and over and over again, don't go to a course and then wait 3 months to put it on a dog or a cat. If you go to a course and take a course and you want to use that skill and build that skill, you got to practice. And a lot of people say, well, yeah, but you're in academia or you're in a referral practice, you have time to do that. If you come to the course, for example, when we do the left atriotic ratios, which is the one that most people seem to be least comfortable with and don't think they have the time to do, every single person that comes in and runs those courses with us can find the left atrium aortic ratio in a healthy dog in under 3 minutes. Then you say, well, as long as your machine's running and it's on and you go to your practice, you will be able to then just pick that probe up and look at the left atriotic ratios in a dog that's received sedation and it's waiting to be induced for a spay or an elective procedure. So you've got a lot of stable animals in the hospital in most situations that is easy to check in an under 5-minute window for these skills. So once you've taken a course, my strongest advice is apply that knowledge on a daily basis. Once you go into practice, and then you're going to find that you find those organs, you build your confidence, and when it's abnormal, you're going to be able to pick that up very, very easily.
I think one of the nicest things about this is that there's really no risk to the patient. It's completely non-invasive. Just as you said, I used to practice a lot on animals that were anesthetized for something else, particularly, dental cleanings or something like that. And you're not losing any time because, your licensed veterinary technician can be doing their job while you quickly scan the abdomen. So,
Yeah,
that's
the
one
nice
place.
Yes,
Yeah.
I was going to say the nice thing you brought up there too is we actually have a number of animals that provide perfect, healthy models for pathology. If you've ever done an exploratory and you're wondering what free air in the abdomen looks like, you scan that patient before you extubate it while it's still under anesthesia, waiting for it to wake up. You scan the abdomen, the non-gravity dependent regions, knowing what to look for, you'll find it. Same thing with fluid. You open the abdomen of a patient for an exploratory and then suture it up. The next day, it's going to have fluid in that abdomen. And the same thing, if you put a cat on fluids on a good clip, it's going to have mild, usually renal pelvic dilation of up to 3.5 millimeters. So we have a number of fairly healthy situations where we can look for things to train ourselves without causing any patient compromise, no stress, no invasiveness, and then get comfortable when it happens to find that pathology.
That's great. That's a wonderful tip. I want to talk about presets and settings. I know we have a very fancy schmancy new ultrasound at one of the practices that I relief at, and those are very intimidating to me. There's different probes types, there's artifact filters, there's all these things. And honestly, messing around with all those presets can really affect the findings. So what steps should veterinarians take to optimize their image quality, particularly if you're not super familiar with your machine, where going into multiple practices, sometimes I'm not?
Yes, 100%. And I'll tell you, there's so many different machines out there. And unfortunately, because of their patented technologies, they don't use the same terminology for the same filter, which makes it extremely confusing. And if you show me a machine and say, Boysen, tell me everything about this machine, the odds are I can't do it. But what I can tell you on no matter what machine you drop in front of me is I can find the key buttons that I need to know to answer point of care. That's only maybe 15% of that machine's capability, if that. So the key things are to make sure that I can find the depth, the gain, and the frequency. And I would say with that, I can answer most questions. So I always find the depth, the gain, and the frequency right off the bat to know how to actually change that depth to make the structure of interest fill roughly a half to 2/3 of the image in most situations. I'm going to make sure I can find the gain so I can change the overall brightness or darkness. People say, what exact gain do you need? Doesn't matter. I never look at the gain. I look at the image. It's like art. I just make it look pretty. Every single beholder has got a different level of beauty when they look at art. Just make it look pretty. Don't need to actually memorize a number so that you can see what you need to see. And then the other one is the frequency. And that one's pretty simple in the sense of the higher the frequency, the nicer the image, the nicer the resolution. The lower the frequency, the deeper the penetration at the expense of resolution. So if I'm looking at cat kidneys, I'll go to a high frequency. If I'm looking at a dog and I want to see really deep into the abdomen at the subxiphoid, I go to a low frequency. And then I'm set. And there are lots of different probes out there. I only use one probe. It's a microconvex. I use a microconvex probe and only the microconvex probe for everything. Are there advantages to a linear? You bet. Would I choose a linear in some situations? Yes. But for point of care, no. Because I can answer everything with just the microconvex. And I'm looking for, like I said, those big questions, binary driven. I can answer that with a microconvex. I can answer that with a handheld. If you said, well, what about parenchymal changes in the kidney? That's not really point of care. I'll go with a linear. If you said, well, I want an exact measurement of the septum on the heart, sure, I'll go with a phased array because that's what I look at the heart with. But I will look at the abdomen, the lungs, and the heart and answer all the questions, left atriotic ratios, pleural line assessment and B lines, all the abdominal structures, regardless of what structure that is. I'll do it all with a microconvex probe. And I'll use those main three settings, frequency, gain, and depth, to allow me to adjust the image. Now, beyond that, what else is useful that people should probably find? The one that's really helpful if you're looking at the left atriotic ratio or you're doing things with a moving patient. So a cat that's going to have a potential low level of tolerance, or a dog that's got a low level of tolerance for standing still. You'll get the image, then it'll move. You hit the freeze button, you can then track back. And you can, depending on the setting, track back up to 30 seconds on some machines. So you have a long way to go to say, yeah, I had a perfect image. I saw it. But the cat moved or the dog moved. I'll track back to that. So freeze and track are probably the fourth and fifth really important buttons to know. After that, if I had to say one thing, I do like the harmonics. The one filter that I like to play with is the harmonics, because it smooths the image. And we're often looking for motion. We're looking for motion with lung sliding. We're looking for motion with the vena cava. We're looking motion with the heart. So anytime I'm looking for something that's moving, I tend to turn harmonics off. Otherwise, if you want a nice smooth image to remove image or motion artifact, you'll sometimes want to have that harmonics on. But that's not something I played with for the first 10 years of my POCUS career. It's only the last few years I'm like, I wonder what this does. And I wonder how much it affects the image. So I started to play with it and realized, there's a huge advantage to this. So you can get a lot done with a minimum number of functions on the machine. And then as you get comfortable with those functions, they're going to become second nature. And that, I think, is when you say, I wonder what next function I can add. Then you can look at the harmonics. You can look at the spectral reduction. You can look at the dynamic range. You can look at the grayscale. There's so many buttons. I'd be lying to you if I said I knew what every single one of them does. But I can answer everything that I need to with those main functions and then slowly build on top of that.
Okay. Let's jump back to that confirmation bias. That is something that I did want to talk about a little bit. So how do we recognize this in ourselves, and how do we mitigate its influence when we're interpreting these findings?
Great question. And I think this is something that exists across all of veterinary medicine. It's not just specific to point-of-care ultrasound, but point-of-care ultrasound, I think, because of the confidence it gives us, is particularly prone to that, especially if we don't keep an open mind on make sure that all of our clinical findings fit with what our suspected final diagnosis is. So it's the same situation if you're really, really thinking this patient's got diabetes. You may try and look to make that high glucose fit the diabetes when in fact it's stress and it has a completely different problem, but you missed the other problem because you believed it had diabetes. Some of the signs fit it. Then you force whatever you find to fit it. You say, oh yeah, it's got a high glucose, that's it, it's diabetes, when in fact it had a completely different problem and it was stress that actually caused the glucose to go up. So it's the same thing with point-of-care ultrasound. If you really were saying, well, I really think that this patient has a reaction to alpha-2 agonists, and therefore when I scan it, I think this is an alpha-2 problem, and you see that it's got a halo sign. The halo sign can be caused by alpha-2s, but it can be caused by a number of other things. And then you overlook the fact that it actually has a disease process and it wasn't the alpha-2 that caused the halo sign. So the confirmation bias just comes into keeping, I think, an open mind and making sure that once you see a particular problem, that you consider that all the clinical findings and everything else fits it, and you make sure that you didn't overlook something else, that if you find free fluid, you don't say, that's ascites, it fits the heart failure because this dog came in with a congestive heart failure, and you decide not to tap, when in fact it's septic. So again, that confirmation bias, you're looking for fluid because it has right-sided heart failure, you believe it does, you see the fluid, you don't tap it because you think that fits the right-sided heart failure. If you tap it, it's septic. That's that confirmation bias. And it really is a matter. It goes across all areas of veterinary medicine. It's an error, a bias that we see across every aspect, regardless of the diagnostic tests we're doing. So I think it's a matter of just making sure you have an open mind, make sure that all the clinical findings fit what your diagnosis is, and that we're not overlooking some of those problems.
And then that kind of leads to my wrap up for this conversation, which is we're going to find things that are unexpected, or we're going to find things that are unfamiliar. And so when that happens, what is the best course of action, for me as a general practitioner, when I find something that is just beyond my level of expertise?
Awesome question. This is where it comes down to knowing your limitations. So most people know what they can and feel comfortable looking for and not feel comfortable looking for. And there's multiple research on this on the human side, not so much on the veterinary side, but the incidental findings. When we see something that we weren't anticipating, what do we do with that? So that's a really, really good question. And if you find something, you can factor it into your decision-making, but you shouldn't make that the emphasis of your final result because you don't have the confidence. So in that situation, whenever you come across something that is beyond your skill set, my recommendation is that's where you need the referral. So it's similar to any other specialty. If you're doing a surgery and you're like, oh, I can cut a lot of things. I can do spays, I can do splenectomies, I can do simple fractures. And then you get a patient that comes in and he needs a total hip. You know your limitation. You're referring it at that point. You know it's got a total hip. You've got the diagnosis. It needs a total hip because you've taken the x-rays, you've got the clinical signs, but you're going to say, whoa, I found this and I can't handle it. I'm going to refer it. Same thing. It's same situation with ultrasound. You come across a problem that you identify. So you're scanning the pancreas and you say, whoa, that looks like a mass in the pancreas. You can factor that in and say, well, this dog's got these signs. I believe this might be a contributing factor, but I'm not qualified. My limitation is not to look at the pancreas and decide that I need to aspirate that or that is or is not a mass versus a cyst. I'm going to send this out to a specialist. So my recommendation is document it, decide how you want to factor it in, but don't overemphasize it, and then refer it for further confirmation. So I think that's probably the easiest way to approach those incidental findings that you think are beyond your skill set and therefore outside your limitations.
Yeah, it's always good to have a set plan though for when something like that pops up. So this has been fantastic. A wonderful conversation. There is one last thing before we let our guests go. We have a little game that we play at the end of our episodes. If you'd like to play with us, it's very simple. It's just a series of would you rather questions. It's just for fun. Just answer off the top of your head.
Fire.
All right. Excellent. Would you rather pick up a relief ER shift on a major holiday or during a full moon?
Holiday.
You're staying away from that superstitious full moon. Okay. If you had to practice without one, would you give up prednisone or would you give up meropitant?
Meropitant.
Gotta have our steroids. All right. Would you rather have a compliant client with a very uncooperative patient, or would you rather have an argumentative client with a sweetheart of a patient?
Sweetheart patient.
Sweetheart patient.
That was
We're going to deal with the angry people.
I can deal with the angry.
Okay. If they could both rate you on Google, would you rather get a review from your last feline patient or your last canine patient?
Canine.
Yeah. I feel like cats are really judgy. All right. Last question. If you had a centaur present with an acute abdomen, would you ultrasound the man's belly first or would you ultrasound the horse's belly first?
Horse.
The horse. Excellent. All right. That was it. You did great.
Excellent. Thank you. That's a tough one to just rapid fire answer because the brain starts thinking and I'm trying to figure out, that's a good question. Which would I? And then it's nope, answer. Okay, there it is.
There it is. Good.
I enjoyed
it was fantastic. All right. This, like I said, was wonderful. Thank you, Dr. Boysen. Please write for us some more and please come on the podcast more because this was great. And just thank you to our audience. I hope you enjoyed this discussion as much as I am. And I hope it inspires you to explore the potential of POCUS in your own practice. Thank you for joining us for today's episode of Clinicians Brief the Podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@vetmedics.com. Clinicians Brief the Podcast is a VetMedics production, produced by Alexis Ussery and hosted by Dr. Alyssa Watson.